We are moving on to our next session. Dr. Panchanan Chatterjee Endowment Lecture. I would like to call the chairpersons for this session. Dr. Pavnitra Lal from New Delhi, Dr. P. Raghuram from Hyderabad, Dr. Subramanian SR from Chennai, Dr. Amit Agarwal from Lucknow, Dr. Barthendu Kumar from Muzaffarpur. And also, the topic of the session will be management of intestinal fistula for the general surgeon. Speaker of this session, Mr. Ian Anderson, President, the Association of Surgeons of Great Britain and Ireland. We welcome all of you to the session. Thank you.
Very good afternoon to everyone. A very warm welcome to our President, Dr. Raghuram, and all the co-chairpersons and the Honorable Speaker, Mr. Ian Anderson. It gives me a great privilege to introduce the person on which the this endowment lecture is named, namely Dr. Panchanan Chatterjee. Dr. Panchanan Chatterjee was born on the 23rd of November 1892 in Bali district, Howrah in Hooghly, in the city of Calcutta. He obtained his schooling in Guwahati, Assam, and later in the Rivers Thompson School in Bali, which is presently known as Santiram Vidyalaya. He joined the Uttarpara Raj College and passed the FA of the Calcutta University. Although he was a student of arts, he was admitted in Calcutta Medical College in the year 1912 as a special case, and that showed his ability in science, being an art student. In the year 1918, he passed the Bachelor of Medicine of the Calcutta University, securing the highest marks in surgery and obtaining all the college prizes in the college for surgery. Dr. Panchanan worked as a senior house surgeon to Colonel Baird, who was the professor of surgery of Calcutta Medical College. In the year 1920, Dr. Panchanan was appointed superintendent cum resident surgeon of the Carmichael Medical College, which is now known as the R.G. Carr Medical College. And in those times when it was such a difficult examination, Dr. Panchanan Chatterjee passed through the fellowship of the Royal College of Surgeons of Edinburgh and commenced his surgical practice in the year 1926. He was appointed as senior visiting surgeon in the Calcutta Medical College in the year 1928, and then professor of clinical and operative surgery and professor of surgery from 1947 to 1952. Dr. Panchanan Chatterjee was a founder member of our association, the Association of Surgeons of India, and was the president of this august body in the year 1949. He was the chairman of the organizing committee of the ASICON held in Calcutta in 1951. He was also the chairman of the proposed ASICON in Calcutta in 1962, but this conference had to be postponed for a year, and he passed away before it was actually held in the year 1963. Dr. Panchanan Chatterjee was a member of the Senate and the Syndicate of the Calcutta University. He was president of the IMA Calcutta from year 1941 to 42, and the president of the Bengal State branch of the Indian Medical Association in the year 1942-43. Dr. Panchanan Chatterjee left us all on the 22nd May 1963. The endowment lecture, started by the Association of Surgeons of India in the revered memory of one of its founder members and past presidents, was started in the year 1983.
Thank you, Professor Pavanendra Lal. A very warm welcome to Professor Ian Anderson. Welcome virtually to India. And I must, at the very outset, mention to the distinguished delegates that Professor Ian Anderson is the recipient of the 2022 Honorary Fellow of the Fellowship of the Association of Surgeons of India. Professor Ian Anderson is an internationally renowned surgeon. He is the honorary chair of the Manchester Academic Health Science Centre and is a lead surgeon at the Salford Royal's internationally renowned Intestinal Failure Unit, which is a national referral center for complex intestinal problems following surgery. He has a particular interest in Crohn's disease, thyroid, and emergency surgery. Throughout his consultant career, he has been involved at national and international level with new surgical developments, with particular interest in surgical critical care. And as many of you are aware, the CRISP course, the Care of the Critically Ill Surgical Patient course, he has been a pioneer in leading to the development of this course, which has actually transformed training in surgical critical care in the United Kingdom. He has had numerous research articles published in lead academic journals and has contributed to many national and international scientific programs. In recognition of his outstanding contribution to medical education and clinical surgery, he has been conferred the very prestigious member of the Most Excellent Order of the British Empire by the Queen. This is a great honor that has been bestowed upon him, and he is the current president of the Association of Surgeons of Great Britain and Ireland, which is the equivalent of the Association of Surgeons of India in the United Kingdom and Ireland. A very warm welcome, and his oration has been recorded, but he's here as well. It's so nice to have you with us. So we go ahead with the presentation.
Thank you for asking me to give the 2020 Dr. Panchanan Chatterjee Endowment Lecture. My topic is management of intestinal fistula for the general surgeon. I accept that intestinal fistulae are not that common, but they are extremely problematic for patient and surgeon alike. And with some relatively straightforward pathways, it's possible to achieve satisfactory management in a significant proportion of these and to select others for safe onward referral to specialist centres when necessary. I work in the Salford Royal Intestinal Failure and Fistula Unit in Manchester in the United Kingdom. This is an expert national unit set up 40 years ago by Sir Miles Irving. We have a large team of expert surgeons, nurses, therapists and dietitians, and take referrals from all over the country. Our stock in trade is the complex open abdomen with multiple fistulae, as you can see. We've built up a large experience of those, but from those come useful lessons for more straightforward fistulae that we all meet. I'd like to share some of those with you today. Intestinal fistulae show enormous variation in their appearances and in their effects. And that variation is reflected internally, as you can see from these operative photographs, from the simple enterocolic fistula on the left to the complex multiply fistulated reoperative pelvis on the right. The operative difficulty varies, as indeed do the effects the fistula will have on the patient. Sepsis dominates the effects which fistulas cause, but close behind that comes high output. With a high output, there will likely be effects on malnutrition and dehydration, and appropriate therapies will be needed. It will also have an adverse effect on how manageable the fistula is for the patient. The second big question is whether the fistula will heal spontaneously, and the factors shown here all tend to point away from spontaneous healing. Many of these will only be determined as investigations take place. While certain diseases cause fistulae spontaneously, in fact 85% of fistulae arise following surgery, and in particular after anastomotic leakage and inadvertent enterotomy. Prevention therefore depends on careful case selection, particular care with surgery in the difficult abdomen, and on a selective approach to the formation of intestinal anastomoses, as well as repair of any enterotomy or serosal tear. It is worth mentioning that intraperitoneal mesh leads to exceptionally difficult reoperative surgery and has become one of the commoner causes of fistulation in our practice. This is a key slide. For simple or complex fistulae, we've had a standardized approach known as SNAP, which we've used for over 30 years. The most important principle is sepsis control, without which treatment will be unsuccessful. Nutrition is required to allow surgery to be successful and the patient to heal. Before a reparative procedure is considered, you need to define the anatomical nature of the fistula, and the reparative procedure only takes place when the patient is ready and the surgeon is ready, often some months after the onset of the process. As with any major unexpected complication, there are common initial steps: critical care, fluid resuscitation, treating sepsis, caring for the fistulated wound, and resting the bowel and instituting parenteral nutrition in most cases. Let's consider two different scenarios and think first about the simple early postoperative fistula, where bowel contents might appear through the wound or through the drain. With successful treatment, perhaps 90% of these will heal without further surgery, and the favourable ones would be those which are not septic, the bowels are working, the fistula output is low volume, and contrast CT scan does not show any abscess and shows that the contrast flows past the fistula site successfully. In these patients, a trial of conservative treatment with bowel rest and ideally parenteral nutrition is justified, and often, with close observation, a successful outcome can be expected. Unfortunately, not every patient will avoid early surgery, and severe sepsis or peritonitis drives the need for early surgery. This can be very challenging, especially if the patient is critically ill or if more than 3 or 4 days has elapsed since the last operation. In these circumstances, the decision to anastomose the bowel is a balance of risks, and usually a stoma is safer. Of course, if it's a proximal stoma, that will mean TPN for a period of weeks or months, and in certain health economies, that may not be possible. Now, most complex fistulas and intestinal failure come from an unsuccessful second operation, such as that which we've just described. If you look at the fistula in this picture, you will see it's not early, it's at least 10 or 14 days old. And if the surgeon operates on this and fails to eradicate sepsis, there will be problems. And if he operates and tries to be too aggressive, then problems can arise. In either circumstance, we can end up with a complex fistula and open abdomen such as we see here, which will then need many months of further treatment to resolve. Our SNAP protocol still applies, and let's talk through cases like this. In managing complex or late fistulae, the diagnosis and treatment of sepsis is even more essential for success, and we use radiology liberally. CT for diagnosis, perhaps 2/3 will have an unsuspected collection, and also for intervention by percutaneous drainage of deep and superficial collections, sometimes on multiple occasions. We would limit surgical intervention at this stage only for life-threatening sepsis or hemorrhage, and certainly any attempt at reconstruction at this stage will almost certainly fail. Indications for surgery for sepsis at this difficult point are shown here. Of course, organ failure due to unrelieved sepsis requires treatment, as does significant dead tissue and failed percutaneous drainage. Borderline cases are not infrequent, and the ease of surgery from the timing in the disease process, the number of previous operations, and the source of sepsis will all contribute to the balance of risks of intervention versus not. Be careful also of the patient with low-grade sepsis who gets building malnutrition despite nutritional support, as they may well have ongoing sepsis also. In these salvage procedures, you need to be realistic about what can be achieved. Eradicate sepsis is the first aim. Get the ends of the bowel on the surface if you can, would follow close behind, and try not to resect length of bowel. If possible, you may plan for future gut function and place big drains, and at the end, you're only going to close the abdomen if it's clean and not tense. Sometimes these operations need to be carried out in a non-anatomical fashion and be little more than a large laying open or debridement of the abdominal cavity. Seen pictorially, here are three of the options, none of which feature any anastomoses. If you can resect and exteriorize, then that's preferable. With pelvic fistulation, a proximal jejunostomy or enterostomy can be used effectively. And if it's not possible to bring out a stoma, then leaving the abdomen open as a laparostomy will often save the patient's life. And here's two examples: a proximal loop stoma for complex pelvic fistulation after diverticular resection on the left, and a laparostomy for duodenal fistulation on the right, with gastrostomy, jejunostomy and sump drains shown also. Closing the abdomen primarily is often not possible or appropriate in these cases, and we use vac therapy liberally. In early cases, we would use mesh-mediated traction, but that of course will not work in later cases of sepsis. An alternative to vac, and much cheaper, is the large fistula bag with access ports, which can be particularly useful in the early phase when further lavage and interventions and replacements of catheters on the critical care unit is still necessary. Here you see a case of pancreaticobiliary sepsis with a laparostomy extended non-anatomically in the right upper quadrant for drainage gastrostomy and feeding jejunostomy, as well as multiple drains, a vicral mesh retaining the viscera, but with sepsis gone and feeding in place. It's remarkable how quickly the open abdomen will heal and granulation develop. Further surgical complications are likely, so it's important that the surgeon remains heavily involved when the patient is on the intensive care unit. We are very fortunate in our practice to have nurses who are fantastic at caring for fistulas and stomas. Protecting the skin and avoiding leakage is essential to the patient's perception of recovery. If the output is high, then we collect the volume either by suction or in a simple collection device, as seen in the slide. In every fistula patient, we reduce the volume of GI secretions with loperamide, codeine and omeprazole, as reducing the fistula volume is a step in the direction of closure where that is possible. Providing reliable nutritional support in complex fistulae really does revolve around the ability to deliver safe and prolonged parenteral nutrition in our practice. It gives us more certain caloric input. It avoids feeding a septic cavity within the abdomen if there's ongoing fistulation internally. It improves skin control around the fistula, helps reduce fistula output, and we're looking at waiting at least 6 weeks to see if the fistula will close with these measures. If it does not, and if the fistula is then mature, we may then consider reintroducing oral or enteral intake as appropriate to that individual case. And this is certainly one area where having a specialist unit and expert nursing staff makes all the difference. Their attention to detail of caring for feeding lines with asepsis and training the patients means that our catheter sepsis rate is outstandingly low. That in turn means that the nutrition can carry on and lets us continue with non-operative management for longer than many other units, which in turn lets the abdomen become more easily operable, and it gives us a greater degree of ultimate success. I am frequently asked whether the fistula patient can eat, and expert views do vary on this. Our practice is to restrict or prevent oral intake, given that our parenteral nutrition is so good, for around 6 weeks while we see if the fistula will heal. The slide lists circumstances where we're very much against oral intake, and ideally we like to see a contrast study down to a maturing fistula to know that there are no secondary internal fistulae which we may aggravate. Hand in hand with that, we should consider which fistulae close spontaneously. I've already indicated that the simple early post-operative fistula will quite often close spontaneously, but among more complex fistulae, one might see that there's a reasonable chance of perhaps 1/3 closing within the first 4 to 6 weeks. That's more likely if the sepsis is gone and the patient has become well, the abdomen's closed, and the fistulas of low output and bowels are working. In our practice, the factors on the right have not been shown to make a difference to fistula closure. This slide shows some reasons why fistulae do not close when you might expect them to. Foremost amongst this is ongoing sepsis or an undrained abscess. Also, fistulae in the open abdomen close only relatively rarely. Malnutrition will prevent fistula closure, as obviously will mucocutaneous continuity and distal obstruction. It's also true that 3 or 4-way fistulae don't close, and if there's active underlying disease, including hernia mesh, then that will make closure very unlikely. And in these circumstances, surgical intervention is going to be needed to resolve the issue. If the complex fistula does not close spontaneously within the first 4 to 6 weeks, then we enter a prolonged recovery phase, typically of up to 6 months, while we try and achieve 2 aims. The first is to restore the patient's nutrition in preparation for surgery, and the second is waiting for the abdomen to soften and become operable. The slide at top right shows a typical case where the fistula is never going to close without surgery. During this prolonged phase, there are pitfalls, as you can see on the slide, foremost amongst which is ongoing or recurrent sepsis. This can be from complex internal fistulas, such as seen in the pelvis in the radiology image on the lower right. Other sources include resistant organisms, including fungi, feeding lines, catheters, and heart valves. While these weeks pass, we carry out radiological mapping to define the fistula in preparation for surgery by updated CT, but also by conventional GI contrast studies. We particularly do not want to overlook second fistulae, a missed distal stricture which would jeopardize any anastomosis, and we also look for urinary tract involvement in appropriate pelvic cases. We like to build a map, as you can see, so that we're clear in our minds what we're dealing with when it comes to surgery. The reconstructive operation will determine the patient's future, and the key consideration is timing. If you have all these factors right, the sepsis gone, nutritional state recovered, the fistula prolapsing to show that the peritoneal cavity has loosened up again, then there's a good chance that the abdomen will be operable. If you operate before this point, then poor outcomes are likely, and you may return the patient to square one. We often wait at least 6 months, and the surgeon has to be ready and prepared, just like the patient. Thorough planning for these reconstructive operations is essential for success. The surgeon must know all the details of previous operations, pathology and radiology, have consulted with colleagues and considered whether referral to another unit is a better option. An operative strategy must then be decided upon. In these prolonged and challenging procedures, it may not be possible to accomplish all one's aims, and priorities are needed. The first is to deal with residual sepsis, the second to create a manageable stoma for the patient, and then functional function. It's essential to consider the price of failure and, if necessary, to carry out surgery in stages, typically with defunctioning of distal anastomoses. It may also be necessary to defer abdominal wall reconstruction to a later date. Unfortunately, we do not have time to go into all the technical aspects of this surgery, but it's prolonged. It's essential to resect the fistula in order to gain success, and that needs all the small bowel to be dissected out. Length should be preserved and the bowel should be checked to avoid leaks. In achieving this, patience is the surgeon's greatest virtue. The question then arises, how many anastomoses can be made in circuit in a single operation? And that, of course, is a balance of risk. If one leaks, then we're back to the start. We usually defunction proximally. If there are several anastomoses, we can then use distal enteral feeding in the several months until the stoma is eventually closed. Similarly, techniques of complex closure of the abdominal wall are a lecture in themselves, and suffice it to say that sometimes this is best deferred and a simple means used. One favoured simple means is the double thickness vicryl mesh. This is absorbable, the abdomen can be closed at either end and the small residual central component patched. Most will form a hernia. This slide shows our results with these techniques in complex fistulae in open abdomen in Salford, averaged over 3 years. This, of course, is in a specialist unit, but I hope you can take some of the techniques which I have described to your own practices, should you need to do so. So finally, thank you very much for this great honour of being invited to speak to you. I'm sorry I cannot answer any questions face to face, but please email me if you have them. Thank you very much.
Thank you very much, Professor Anderson, for that excellent talk. I'm sure this was a delight to all the surgeons who were audience to this oration. On behalf of the Association of Surgeons of India, we thank you for this talk, and as is customary, no questions are asked at the end of an oration. So, but I'm sure this has brought in so many insights into the management of both simple and complex intestinal fistulae, and it's a great coincidence that I've had the opportunity to visit your world-renowned intestinal failure unit at Salford, and one of my cousins actually happens to work as a close colleague, Simon Lal, at your
That's
center.
good.
So, it's just very coincidental that we are together sharing this dais on behalf of the Association of Surgeons of India. It's our great privilege to present with you the memento and the plaque, which will read out the citation read out by our president, Dr. Raghu Pilarasetti, and this will be sent to you,
Thank you.
from the office. So thank you very much once again for being with us today. Thank you very much. And thank you to all the chairpersons as well.
It's a great pleasure. Thank you very much indeed. Look forward to seeing you in due course.
Very nice. Lovely meeting.
Thank you very much, sir.
Thank you.
Thank you so much.